I'm Richard Kellner, and I am the founder of the PKD Outreach Foundation. My family's been dealing with PKD for over 40 years. My mother-in-law had 2 kidney transplants. My late wife, Joanne, had PKD. I donated a kidney to her 10 years ago. Unfortunately, she did not survive the pandemic. My sister-in-law has PKD. She's been on dialysis for 10 years. Both of my kids have it, as does my nephew. But thanks to what we're going to talk to you about today, my grandchildren will not have PKD, and their future generations will not have it either. So for my first 30 years of dealing with PKD, I was told by the medical professionals there was nothing you could do about it until your kidneys failed. It's my understanding that they're still teaching this in medical schools today, but it's a myth, and we're here to dispel that myth and let you know that there is something you could do about your PKD. In 2023, we launched our PKD-Free Babies initiative to create widespread awareness about the only time-tested, medically proven solution to prevent PKD from being passed down to future generations. We also provide funding for those in need where the procedures are not covered by insurance. As you will learn from the experts today, this is not new. It's actually been around for over 25 years, and it has been successfully used to substantially reduce other diseases. We are hosting this webinar on World Kidney Day to emphasize the point that eliminating PKD will actually help all people in need of a kidney by reducing the waiting list for a kidney for all in need by years. I would now like to turn this over to our moderator, Caitlin Phoenix. Caitlin is a deputy editor in the Hearst Health newsroom, where she reports, writes, and edits research-backed health content for Good Housekeeping, Prevention, and Women's Day. She has more than 10 years of experience talking to top medical professionals and poring over studies to figure out how the science of our body works. Beyond that, Caitlin turns what she learns into engaging and easy-to-read stories about medical conditions, nutrition, exercise, sleep, and mental health. Caitlin, thank you for being here. The floor is now yours.
Thank you, Richard. I'm so excited to be here and help spread the word about polycystic kidney disease and the pkDO Foundation. I will start with a brief introduction of our panelists for today's discussion. First, we welcome Dr. Heedeok Han. Dr. Han serves as an assistant professor of medicine at Columbia University Irvine Medical Center, specializing in polycystic kidney diseases and the transition of care for patients with advanced kidney disease. With a deep commitment to advancing patient care, Dr. Han holds the position of Associate Director of the PKD Center at CUMC. Next, we have Dr. Sinem Karipcin, board certified in both obstetrics and gynecology and reproductive endocrinology and infertility, and assistant professor of obstetrics and gynecology at Columbia University Medical Center. Dr. Karipcin leads a multidisciplinary team of experts to help couples have a healthy child without the risk of severe genetic disease. Rounding out our panel of experts is Stephanie Galloway. Stephanie is a board-certified genetic counselor who specializes in reproductive genetics. Since joining Columbia in 2017, she serves women and families throughout their family planning journey, specializing in REI, embryo genetic testing counseling, preconception genetic risk, and prenatal genetics. Welcome to all of you. We are honored to also have Katherine and Michael Black. Kate and Mike are parents to 17-month-old Eloise. Mike has polycystic kidney disease and received a kidney transplant over 10 years ago. When starting their family, they knew they wanted to do everything they could to prevent their children from receiving a PKD diagnosis, which led them to IVF and genetic testing. Let's get started. My first question is for Dr. Han. Let's start with the basics. What exactly is polycystic kidney disease, also known as PKD, and how is this different from regular chronic kidney disease?
Hi, Caitlin. Thank you for the kind introduction and having me on this panel. As the Associate Director of our Polycystic Kidney Disease Center at Columbia, I'm very thankful for the opportunity to be able to take care of such inspiring group of patients. Regarding your question, autosomal dominant polycystic kidney disease is actually one of the most common hereditary conditions overall, and certainly so in terms of hereditary kidney disease. Although its prevalence can vary depending on which study you look at, it is estimated to occur in about 1 in every 400 to 1 in every 1,000 live births. It is one of the leading causes of end-stage kidney disease globally, accounting for about 5 to 10% of the cases. The name of the condition, autosomal dominant polycystic kidney disease, can be broken down to explain the hereditary pattern and the pathology of the disease. It is an autosomal dominant genetic condition where the pathogenic gene can be passed down from either one of the parents, and if one copy is present, it will be expressed and the carrier of the gene will have this disease. Because you only need one copy to have this condition to be expressed, there's often a strong family history of kidney disease for this condition. This is different from an autosomal recessive condition where you need one pathogenic gene mutation from each parent, and often family history is not as apparent. There are also some cases where genetic mutations occur in that generation, and which leads to this condition despite not having either parents being affected by it. This is called de novo mutation and can occur in about 4 to 10% of the cases. This genetic mutation controls signaling pathways in the body that regulate cell growth and fluid secretion. Those who have the pathogenic mutations are actually born with many cysts in the kidney as they are formed prenatally. However, because of most of the cysts are very small at younger ages, patients are often not diagnosed until later stages of their lives. Although new cysts can form, most of the cysts are pre-existing and become more prominent as time passes. And as cyst size grow, they start to interrupt the structure of the unaffected kidney cells and compromises kidney function. Kidney function often remains normal in the early stages due to maladaptive changes by the remaining kidney cells, but over time, kidney function declines to about 70% to the point where 70% of the patients with ADPKD progress to end-stage kidney disease by age 70. The gene for ADPKD, despite the name containing the word kidney, is not limited to just the kidneys and can affect other organs such as blood vessels going to the brain, liver, spleen, pancreas, and many other parts of the body. Lastly, it differs from other forms of chronic kidney disease in several ways. Although there are many different causes of chronic kidney disease, PKD being one of them, the management and presentation differs for each cause. The most common cause of chronic kidney disease around the world are diabetes and high blood pressure, which are systemic conditions. Many times when patients have chronic kidney disease from these two causes, they have other organ dysfunctions such as dysfunctions in the brain, the heart, and the nervous system, to name a few. Management of these patients also differ, but patients with ADPKD have less systemic conditions and tend to have better outcomes at similar stages of chronic kidney disease and end-stage kidney disease.
Thank you so much for that explanation. My next question is for our genetic counselor, Ms. Stephanie Galloway. So a couple has learned they have PKD, but are looking to start a family. What are the chances of a baby being born with PKD? What do you say to couples at this stage?
Thank you. As Dr. Han explained, PKD is hereditary. And often the couple or partner with PKD grew up around others with the diagnosis, and this shapes their perception. They often aren't the only person in their family with the condition and have probably seen a variety of symptoms in their family members. They might understand that PKD runs in their family, but haven't fully conceptualized that they can pass it on. Or the opposite, knowing this runs in their family, they may think their children are doomed for it. So to set expectations, it is helpful to review with the couple the specific risk, that each offspring has a 50% chance of inheriting this condition, and the inverse, that there's a 50% chance they don't inherit it. So what do I say to a couple at this stage when they're wanting to build their family? I have a conversation with the couple. They share their history with the diagnosis and condition, and I ask about their goals, their dreams, and their worries around growing their family. And in light of their desires, we review the couple's options for assessing and understanding their children's risk. And the couple weigh these benefits and limitations through the lens of their desire. Families have the option to conceive naturally, choosing testing for PKD if the pregnancy has symptoms, or testing and screening a child or an adult at an appropriate age. The benefits of natural conception include cost. It's fairly inexpensive, as well as some couples describe it as the natural way of things. However, there might be heightened anxiety and worry through the pregnancy and adolescence waiting for symptoms. Or the couple can choose and consider assistive reproductive technologies with in vitro fertilization or IVF with genetic testing for their specific cause of PKD. And without going into the specifics of embryo genetic testing, I do want to emphasize that in order for us to screen the embryo for PKD, we need to know the specific genetic change in the family to accurately test the embryo. ART or IVF, unfortunately, can have a high upfront cost, ranging in the several $10,000 range and higher. IVF also cannot guarantee a pregnancy, just like a natural conception, but this is often a misconception of IVF. However, if a low-risk embryo is successfully transferred, this might produce comfort for the family and the parents, knowing that they likely stopped this disease from continuing in generations. Neither option, as I mentioned, can guarantee a pregnancy, and neither option allows parents to test and screen for every health concern. So there are many things to consider in paths forward for growing their family. I just want to end and summarize this with how this is not a one-path-fits-all situation. And choosing one option does not mean you can never do the other option. Through this conversation together, the couple is able to make a plan that's best for them in building their family.
Thank you so much. Dr. K, as our IVF specialist, can you please share how a couple with PKD can prevent it from being passed down to their children through the IVF PGTM process?
Thank you so much, Caitlin. And I'll take off from where Stephanie left. Yes, we first needed the genetic testing report that explains the genetic condition in the family of that affected individual with the kidney disease. And if they don't have testing, our colleagues at nephrology, like Dr. Han and our wonderful nephrology genetic counselors, they'll assist us to get that person tested. And once we have the molecular diagnostic report, then we could start preparing for testing the embryos, okay? So the process for embryo genetic testing for a single condition is called pre-implantation genetic testing for monogenic disorder. So why are we preparing for testing the embryo as we are testing the individual just from a blood sample or a saliva sample? Why? Because the embryo is such a small structure, and we are going to take a biopsy of 5 to 10 cells from such a small structure. So we need to amplify that small DNA sample to get that accurate information. So we are looking at the family-specific markers surrounding the variant of PKD in that case. So that's why we are preparing for testing. So first, the molecular diagnostic reports, the genetic testing, then preparing for testing the embryos, which could take 5 to 8 weeks. Then once the lab, PGT lab, gives us the green light and we are okay to move forward with the testing, then we start the ovarian stimulation. So in other words, that's growing multiple eggs. So the woman typically starts going through the treatment, starts this treatment with the period, and this takes about 2 weeks. It's daily injections under the skin that they administer to themselves, and ultrasound and blood work monitoring during that 2-week process to grow the eggs. After that, we collect the eggs, and when we are collecting the eggs, we give the patient anesthesia through the IV, so they're asleep, they don't feel that procedure, and we collect the eggs with no incisions through the ultrasound, vaginal ultrasound, and then we put the egg and the partner's sperm together. So the partner gives us a sperm sample the day of the egg retrieval, and we need to inject the eggs with the sperm because we want to get the information from only the embryo. After the fertilization occurs, then we culture the embryos to 1 week stage. At that stage, they form, the ones that form the blastocysts, we biopsy what makes the placenta, and then we freeze the embryo right after. And as we wait for the results of the biopsy sample, the embryo could stay frozen. Even after we get the results, the embryo could stay frozen. And the data analysis occurs after that, about 3 weeks or so after we get the results. And we do an embryo transfer, typically 1 week after the ovulation occurs. This is a minor procedure, just like having a pap smear in the gynecologist's office, just to put the embryo with a gentle catheter back inside the uterus. We transfer only 1 embryo at a time, and about 2 weeks after that, you know whether you're pregnant or not from that embryo transfer. But a couple could come to us really, really young, even before they want to have kids, and store embryos, and whenever they're ready, they could transfer the embryo. And so there is no shelf life of the embryos that are frozen. And also, one thing to emphasize here, as Stephanie said, IVF is not 100% successful, and the most important factors are to come to do those treatments when we are young, when we have good ovarian reserve, because we need to work with multiple eggs to ensure we are making embryos that are going to be unaffected with PKD and also chromosomally normal.
Now let's turn to Kate and Michael to learn more about their own personal experience. First, what has been your family history with PKD, and how has this experience with PKD affected your approach to starting a family?
Yeah, so my grandmother and my mother both had PKD. I'm not sure the year, but I remember my grandmother being a transplant recipient and taking lots of pills for it. We were all like little kids, and she just was always taking pills. Other than that, we don't really remember talking about it that much. When we were like really little, my mom had us all do ultrasounds and check to make sure that we were in the clear, and at the time we were all okay. Fast forward to 2007, my mom had a kidney transplant after being on dialysis for several years, and that was, being on dialysis is not fun at all. She had to do, where you get yourself hooked up to the machine overnight. I don't know, perennial dialysis. I don't know the name for it, but later that year, so it was 2007, later that year I was hospitalized for a severe kidney infection. While performing an ultrasound, they found that I had cysts on my kidneys, and that's when I was officially diagnosed with PKD. After that, my sister was also diagnosed with PKD. It was like one of those things, I was diagnosed with it. Hey, get yourself checked out. I know we got checked out when we were little kids, but get yourself checked out. So I have a brother and a sister. My brother thankfully does not have it, so it's just me and my sister. In my case, even with treatment, the PKD progressed fairly quickly, and by 2012 I had started to become quite ill. I was really tired all the time due to my declining kidney function. I remember I was still working, full time at that point. I remember working all day and then being exhausted by the time I got home and just wanting to go and go to sleep because I had no energy at all. Later that year, I lost my mom due to complications from her kidney transplant, being rejected. She basically had a brain aneurysm and never woke up from that. And it was around the same time I was told that I needed to basically start dialysis or find a donor. And thankfully, in December of 2013, I was given a new lease on life after undergoing a kidney transplant from a known living donor. The kidney transplant has been successful, going on 11 years now, and I'm incredibly thankful for the gift. I don't know if I would be here today without it. You know, something that I think about every day. My sister's PKD has been monitored since the diagnosis, and her kidney functions are stable at this time, which is great. I think they just found it earlier in her, so they've been able to you know, do the medications and keep it under control. Needless to say, after all the struggles and the recovery after the transplant, I thought children were completely off the table for us, because I never wanted to pass that along to a child. You know, it was hard, so I just never thought it was in the cards for us.
And can you share us a little more about your experience with IVF and PGTM to have a PKD-free future for future generations of your family?
Yeah, so Mike and we started dating after his kidney transplant, so I only, knew him as somebody with a kidney transplant and polycystic kidney disease. So that was back in 2015. We were living in Columbus, Ohio. That's where Mike's from, and I was living there for a job at the time. We had talked a little bit about kids, early in our relationship, and we had expressed, we had talked about not wanting to spread or pass on PKD, and I am somebody that does a lot of research. So I kind of did a little research. My sister was actually an embryologist at the time, in between undergrad and grad school. So I kind of had a general understanding of what she did, and so knew that there were some conditions that were able to be tested through the IVF and genetic testing process. So I kind of went down the rabbit hole and found some literature that was possible with PKD because of the dominant genetic condition. So I paid, out of pocket consult fee at a clinic in Columbus just to talk to somebody and get some validation on what I was thinking from a professional. They indicated that we'd be a good candidate. But, as we've all talked about, IVF is extremely expensive, and because we are testing for a dominant gene, the chance of every single embryo being able to transfer is pretty low when you consider the genetics and the chromosomally normal. So we were worried that one cycle wasn't going to do it, and that we weren't sure if we were going to be able to afford it. I'm from New York State originally, upstate Syracuse, and I knew from family and friends that being a state employee for the state of New York, they provided fertility coverage, and at the time neither of us had that in Ohio. So I started not shortly after, but in the next couple of years started looking into positions in New York and trying to make a plan to figure out how we could do this. So then in the fall of 2018, we moved back up to New York, to Albany area, and then we had our first consult with a different fertility clinic, the summer of 2019. We, as Mike said, it would have been nice to have kids the traditional way, but I don't know if either of us could have lived with the guilt if we knew that there was something we could have done, and we didn't, so.
Thank you so much. That's so interesting. Could you share a little more about your IVF and embryo genetic testing journey?
Yeah. So we had our consult with a fertility clinic in upstate New York when we moved, and between that and our original consult that we had back in Columbus, we had received a lot of positive feedback, and while there are no guarantees, they expected with some of the lab work we had done that we would have good results. But unfortunately, our IVF journey was not that simple. getting the proper testing completed, as others have mentioned, and building what's called the probe, is what's tested, what our embryos are tested against, was a big lift. For one, by the time like Mike got his, since Mike was clinically diagnosed and didn't have genetic confirmation, that took a while. And then it was spring 2020, and everything, you know, our IVF clinic shut down, and because they were deemed non-essential in the beginning. And then we were asking our family during the pandemic to go get tested to help in the creation of the probe. So that took a really long time. I also didn't want Mike. We didn't want Mike going to get lab work that wasn't, you know, medically necessary during those early months of the pandemic. So all in, we got everything we needed. The probe was finally built, and that was in late summer of 2020. And we started our first embryo transfer, egg retrieval that fall. Everything was going really well. I forget how many eggs were retrieved, but a respectable number for my age and what the results were during the process. And then none made it to day 5 for testing. So when we had our follow-up consult, the IVF clinic indicated that it was very weird. They couldn't explain it. It was a fluke. Change nothing, do it again. So I think November, we did it again, and I think we had one make it to testing, and it was, I feel like it had PKD and was chromosomally abnormal. Like, it was just not, it was just bad. So the clinic suggested that I take some pretty intense drugs and to change some supplements I was taking, and that, you know, again, it's bizarre. This shouldn't be happening. Let's try it again. So I think maybe that February or March, is back to back to back. I did it again, and I think this time we ended up with 2 that made it to day 5. And again, they were just a mess. Nothing could be transferred. So we did one more, and thank God for insurance, because this would have been, you know, now we're talking about going on to our 4th cycle. And again, it was terrible results, no transferable embryos. And when we talked to the clinic and the doctors, they didn't know. They had no reason. It was unusual that we shouldn't be having these results. We were done at that point. We had, you know, luckily we have fertility coverage for the actual treatment, but it didn't cover the creation of the probe and the genetic testing. So that was a big out-of-pocket expense in the beginning. And then once we hit the genetic testing covered like a certain amount of embryos with like your, you know, one-time purchase, and then any additional embryo costs an extra $500. And we were just sending embryos for them to come back and tell us that they were terrible. So I had asked, I've been on a Facebook group and just asked if anybody had good experience with another clinic, or if they had anybody that had, like, you know, worked miracles for them. And Columbia had been thrown around, and specifically Dr. K. So, you know, I called our insurance and made sure that there was still money left in our allowance to, you know, potentially do another one. And we still had money in that account. So we did a virtual consult after we had to send over, like, I don't know, 3 binders worth of history from the other clinic. You know, it was like 4 transfers results in a lot of lab work and a lot of materials to send over. So she had done during our consult, had done a very quick, like, little research on potential issues, and she had found that, you know, maybe some of the medication that Mike was taking was having some issues, causing some issues for us. So she, you know, said, I'm going to reach out to our genetic counselor. We're going to do a little research, you know, talk to maybe some other doctors and see if there's anything to this. And they came back and said, you know, there's really not a lot of research in humans, but there is some indication and some animal testing that it is maybe having, this medication maybe is having some, causing some issues with the DNA of the sperm, and that could be a contributing factor, and that, you know, that they could do an extra step. I don't remember what that step is called, but they could do an extra step and we can see if that does anything. So we decided to do one more retrieval and try for a 5th time with Dr. K in Columbia, and we got a lot of embryos that made it to day 5 compared to what we had been getting to get tested. And while it doesn't sound that great, but we ended up with one good embryo that didn't have PKD, that was chromosomally normal. But we had always hoped to have potentially more than one child, and just having one is, you know, like as everybody says, just because you do an embryo transfer doesn't mean it's going to stick. So we decided to do one more. So we got our results back in late September. We had our COVID wedding that had been rescheduled that fall, and then that November we did one more, and we had great results. Now we have 6 embryos from that cycle that were on ice. So we decided to move forward with the transfer. We transferred our embryo from our first cycle, I believe, and it stuck. And now she's almost 18 months, and she's great. We had a great pregnancy, and it worked.
Okay. Michael and Kate, what was your family's reaction to using PGTM to have a PKD-free child? Essentially, this is ending PKD in your family, which is a huge and exciting thing.
I think they're very excited about it, and I'm very happy to not pass this along to like a next generation. You know, to have them not have another thing to worry about is amazing in my eyes.
And we often joke that the cost of IVF and genetic testing, will make up for it, because they won't have to pay for medical care for kidney disease.
Right.
So we're saving money in the end by doing it this way.
Right. All the kidney stuff is a whole nother expense. Yeah.
Thank you for sharing that. Dr. Hahn, I want to bring this discussion back to you. We've been told there's nothing we can do about PKD until your kidneys fail. Is that true?
Yeah, thank you for the great question once again, Caitlin. And before I go on, I just want to thank Mike and Kate for your wonderful story. As an associate director at our center, I see many, many patients with PKD, and it's really hard to fully empathize and understand what patients go through unless we hear stories. So thank you for that story, and congratulations on your child, and congratulations on keeping your transplanted kidney for 11 years. That really is a testament to you being such a good steward of that kidney and of that gift. So thank you so much for that. Now going back to that question, first and foremost, not all ADPKD patients present the same and have different prognosis. As Mike said, he experienced symptoms much earlier compared to what his sister may be experiencing currently. There are many different factors that help us determine the prognosis of ADPKD, including family history, size of the kidney, type of genetic mutation. I can't go into all the details right now, but essentially, if you have a family member who required dialysis or kidney transplant at an early age, have enlarged kidneys, or have PKD1 genetic mutation, which is the most common genetic mutation, you're at a higher risk of progression than patients who do not have these factors. Once we identify patients who are at higher risk of progression, I'm a true believer that it takes a multifaceted approach to slow down the progression of kidney disease. As a provider, I value patient empowerment through patient education, and that is why I truly believe platforms like these are so important. To start, lifestyle modification is an important first step for patients with ADPKD. There's evidence that increased BMI, high caloric intake, and high salt intake is associated with more rapid disease progression. So one of the first things that I offer my patients is a consultation with our nutritionist at Newark Presbyterian Hospital. Our nutritionists not only have knowledge in ADPKD, but they also specialize in chronic kidney disease and kidney stones, which are pertinent to patients with ADPKD. There are other dietary changes such as ketogenic diet, intermittent fasting, caloric restriction that have shown some signals in different stages of research, but at this time it is important to do it under medical guidance as certain types of diet may not be suitable for certain patients. Also, dietary recommendations may vary depending on stages of chronic kidney disease. Regarding diet, one of the other things that has been traditionally recommended for patients with ADPKD is high water intake. Studies have shown that a hormone called arginine vasopressin, AVP in short, which is released in response to dehydration, plays a role in cyst growth, and inhibiting this hormone slows down the rate at which the cysts grow. There was a recent study, however, that looked at the effect of prescribed water therapy compared to ad-lib water intake, which actually did not show a difference in rate of cyst progression. However, in this study, the adherence to therapy was only about 52%. So given this finding, high water intakes can still be considered with guidance from medical providers, as patients with decreased kidney functions have impaired ability to excrete excess water and may develop complications from consuming significant amounts of water. Other lifestyle modifications can be incorporated, and it includes exercise, smoking cessation, and decreased caffeine intake. I try to equip my patients with the points that we discussed here, and many of my patients appreciate this approach. It helps me build an actual partnership with my patients. Medically, it is important to control other comorbid conditions such as hypertension and diabetes. In patients who are at high risk of progression without severe kidney impairment, there should be consideration to lower the blood pressure to a goal of less than 110/65 using a certain blood pressure agent with a mechanism of inhibiting this blood pressure modulating system called renin-angiotensin-aldosterone system. This is a main system that is involved in controlling the blood pressure and salt excretion in our body. There's also a medication called tolvaptan, which inhibits the action of previously discussed arginine vasopressin, which has shown to decrease the progression of kidney disease as well as cyst growth. This has made a big difference in our PKD community, and long-term prediction models show that it can increase the time to dialysis or kidney transplant. There are side effects associated with this medication, with the most common being thirst and frequent urination, as its main function is to prevent kidney from being able to reabsorb water. Rare but serious complication is liver injury, and patients who are started on this medications have their labs checked prior to initiation, but also monthly for 18 months, followed by every 3 months for the duration of the therapy. It is a long-term medication, and it is only for patients who are at high risk for progression at this point. So far, this is the only medication that has shown to slow down kidney disease progression and cyst growth. Lastly, with initiatives from Mr. Kellner and the PKD Outreach Foundation and work from Dr. Karipcin, we can now give patients an option to prevent passing this condition to the next generation. Every patient that walks through our PKD clinic, regardless of their gender and age, is given a folder that contains information about the PKD Outreach Foundation and our pre-pregnancy genetics program. Platforms such as this helps us increase awareness about this condition and hopefully #EndPKD. Thank you.
Thank you so much to Richard, Dr. Hahn, Dr. Karipcin, Stephanie Galloway, and of course, Michael and Katherine. We hope this provided a little insight into PKD and the pkDO Foundation. As Richard mentioned, for more information, please visit pkDO.org, and we look forward to having another webinar again soon.
Thank you, Katherine and Michael. Thank you, Dr. Hahn. Thank you, Dr. Karipcin. Thank you, Stephanie. And thank you, Caitlin, for all participating and sharing such important and insightful information. As you've just heard from the experts, the path to a PKD-free world exists and has been successfully used to substantially reduce other diseases before. We are now at the beginning of the end of PKD. As of February 2024, our PKD-Free Babies Initiative has enlisted the support of 7 medical center partners, including our esteemed guest from Colombia. We've had over 70 people sign up for our registry to learn more about our financial support program, with over half of them working with us towards having a PKD-free family and most excitingly, we've had 4 babies born as part of this program, PKD-Free. If you'd like to learn more, please follow us on Instagram at PKD_outreach. And if you'd like to apply for financial assistance, you can find us on the web at www.pkdo.org/babies. And thank you again for all of you being here.